Good afternoon, all. I am Dr. Gorakh Mandrupkar, Secretary, World Justice Organization India Chapter, and Chairman of Medical Disorders in Pregnancy Committee during 2016 to 19. Today, we are going to discuss the hypertensive disorders in pregnancy and the complications mainly. First, at the outset, I thank Dr. Alpesh Gandhi, President of the FOXI, because we all know that we are in lockdown and we are suffering a lot because of the COVID-19. But during this lockdown period, we should not lose our spirits. And as our Prime Minister Narendra Modi ji has said, we should keep the social distancing, and at the same time, we should not lose our spirit and we should work for India. Taking this, Dr. Alpesh Gandhi has immediately started the webinars, and this is the 5th webinar, and I thank him for the opportunity. So let us start about the hypertensive disorders in pregnancy and the complications. We all know that giving birth should be ideally a time for celebration, but for more than 500,000 women each year, almost one every minute, pregnancy and childbirth end in death and mourning. 6%, approximately 1 in 16 of the preeclamptic patients, they develop one or more major systemic complications. So many maternal fetal deaths or near miss, they are associated with the substandard care. Hypertensive disorders in pregnancy per se are the spectrum of disorders ranging from already existing chronic hypertension in index pregnancy to complex multisystem disorder like preeclampsia, leading to the complications like eclampsia, HEL.LP syndrome, acute renal failure, pulmonary edema, stroke, and left ventricular failure. We know that severe preeclampsia and these complications, they are the major causes of maternal and perinatal morbidity and mortality. Among all the maternal deaths, almost 19% of the deaths are due to hypertension in pregnancy as per statistics given by the WHO. Despite the phenomenal number of mothers, they are seeking hospital-based delivery care. So this is a big problem. In India, during the period of Dr. Sanjay Gupta, when he was president of FOXI, we started National Eclampsia Registry. Now it is known as the National Eclampsia Registry, NER, FOXI, ICOG. The interim statistics reveals that the incidence of hypertensive diseases during pregnancy to be high, with a substantial incidence of eclampsia. The incidence may be higher because many eclampsia cases which are managed by peripheral health workers, they remain unreported. Let us take the overview. What is the problem? We all know that the defective trophoblastic invasion in early first trimester of the pregnancy is the main cause for this hypertensive disorder. We call in other way as gestosis, that is defective trophoblastic invasion in the early part of the pregnancy. This endothelial damage, as is been shown in the center, the hematological changes that take place, maybe some humoral factors, they are playing the role. When there are problems in the liver, there is altered LFT, periportal hepatic necrosis, subcapsular hemorrhages, and the complications, even the HEL.LP, that is hemolysis, elevated liver enzymes, and low platelets. When it affects lungs, because of the leaky capillaries, pulmonary edema, ARDS is common. When it affects the brain, it's the hypertensive encephalopathy, ischemia, infarction, vasospasm, the PRES syndrome, which is especially in the postpartum period. On cardiovascular system, cardiomyopathies, acute myocardial infarction, and even the contractility usually unchanged and whatnot problems take place. In kidneys, acute kidney injuries, fetus, it is the fetal growth restriction, preterm delivery, abruptio placentae, they are very common. So, when we see per se the complications, they are either acute, they are in future pregnancy, or they are late complications. But today, in this presentation, we will be dealing a few acute problems of hypertensive disorders of pregnancy. Before going into the complications, a few words for the prediction and prevention. As in COVID-19, we are leading, the Indians are leading in the prevention and the protection against the COVID. Here also, in the case of maternal mortality, we are suggesting to the world about two things. First, to use gestosis, real meaningful nomenclature, instead of toxemia, PIH, preeclampsia, HDP, etc. And we are again suggesting the world to use the gestosis score for prediction. What is gestosis score? It is a simplified, dynamic, feasible, and systematic quantification of maternal risk factors for effective screening of hypertensive disorders of pregnancy. Initially, we were calling it as a prediction method. Now we are using the word as a screening. That means every pregnant woman must undergo this prediction system or the screening methodology. I'm fortunate I developed the gestosis score under the guidance and it was modified by Dr. Sanjay Gupte, Dr. Suchitra Pandit, our President Foxy, Dr. Alpesh Gandhi, Dr. Girija Wagh, and now it is accepted in the Foxy gestosis ICOG good clinical practice recommendations of 2020. They are available on, these guidelines are available on the ICOG and Foxy website as well. Please go through the recent guidelines. What is the gestosis score? What we have done, we have collected all these risk factors, all the mild, moderate, and the high risk factors, and we have given them the value to the mild, each mild risk factor as 1, each moderate risk factor as 2, and each high risk factor as 3. So these are some of the risk factors which you are able to see on the screen. These are certain where we have given the 2. When we talk about the maternal hypothyroidism in an isolated manner per se, when we are talking about hypothyroidism, we say there that these women are very high risk to develop the preeclampsia. But if we see the other part of the Western guidelines, though all these clinical factors are taken into consideration, certain factors like diabetes, hypothyroidism, they are not taken into consideration. So we are considering here as well. And the last almost 8 factors, they are high risk factors and the value given to them is 3. So points 1, 2, and 3 are allotted to mild, moderate, and high risk factors associated in causation of preeclampsia respectively. And we have to just do on a piece of paper, and even our A&M can do that. A simple doctor can do that. And if the total score is more than or equal to 3, the pregnant women should be marked as at risk for HDP. And once the gestosis score is more than or equal to 3, we have to start the preventive measure in the form of aspirin 75 mg daily in the night, along with calcium 1 to 1.5 gram daily at the recognition of more than or equal to 3 gestosis score early in the first trimester till 48 hours prior to the labor induction or delivery. Again, there will be, you may ask a lot of questions on the dose, but I am making it very clear that optimum dose of the aspirin is unclear. Many studies have used 60, 75, 100, 150. Low dose aspirin has a good maternal and fetal safety profile, but number of pregnant patients exposed in various studies, I have gone almost 87 studies, but the number of pregnant patients exposed to the doses over 100 milligram in the world is low. Though recent some guidelines or recent some studies are claiming that 150 milligram is okay, but the safety of the prevention based on the 150 milligram of aspirin per day has to be yet confirmed. So aspirin 75 milligram is readily available and please use it. Why I am saying that Justosi score is dynamic? Because in every visit, we can add the simplified additions can be done, identification of the risk can be done. Every visit there is opportunity to reduce the risk, and every visit there is opportunity of prevention again at no cost, because screening methodology has to be cost effective, it should be applied to every single pregnant woman, and it should be cost effective. So, and can be done easily for all. So I can say again, this is a gift to the world by India. So coming to the acute complications of HDP. The CNS complications, mainly the preeclampsia, acute respiratory failure, that is ARDS, pulmonary edema, hepatic complications like HELLP syndrome, serious complications like hypertensive crisis, uteroplacental complications like we know fetal growth restriction, then antepartum hemorrhage and whatnot, preterm labor, acute kidney injury, hematological complications like DIC. But all the complications, they are special chapters, special subjects for the talk. And when I was talking with our president, Dr. Alpesh Gandhi sir, he told that almost the DIC, then eclampsia per se, the preterm, and many things, DIC, there will be webinars on those subjects specifically. So today I am going to cover certain topics which are less touched. So let us start with the PRES. PRES is a posterior reversible encephalopathy syndrome. And this is a rare disorder associated with acute hypertension. Its exact incidence remains unknown. As we are seeing, this is a city picture where it has been clearly seen what is happening, especially in the occipital area. The pathogenesis of the PRES is not clear. It seems to be associated with the rapid development of hypertension that leads to the malfunction of cerebral autoregulation. In particular, why it is called posterior again, the occipital lobe, where the sympathetic innervation is less widespread, resulting in focal vasogenic edema. Other conditions which are related to the PRES, they are also chemotherapy, again infection, sepsis, autoimmune diseases, and hypercalcemia. That means those conditions which are causing cytotoxic edema. Indeed, a leading hypothesis suggests a crucial role for the endothelial dysfunction and activation of the PRES pathogenesis. It is characterized by transient neurologic signs, including headache, visual changes, seizures, and altered sensorium. Typically, the postpartum patient, when she presents with headache, visual changes, seizures, especially in postpartum period, we should think of PRES, just a CT or MRI, because now patient is delivered, there is no problem. We can do either modality which is available. Definitely we can get the clear-cut picture of it. It is reversible in a few days, but if appropriate management is tried. But if the management is delayed, there is high risk of permanent neurological damage secondary to cerebral infarction or hemorrhage and transtentorial herniation. Even deaths are reported, though few. As I already shown, what are the clinical manifestations? This is a very good case report, as well as this is a very good literature review, very recent. It was done in 2019, very recent, and they have given a very good picture of the comorbidity, then the onset. They have also agreed that in late puerperium there is onset of this PRES. The instrumental diagnosis, other than CT, this MRI or the combine, it has given a good diagnosis. Seizures, they are present in almost more than 83% of the cases. Other symptoms like other neurological symptoms, as I said, altered sensorium, headache, etc., they are more common. When treatment part of was considered, Then yes, the anti-epileptic and anti-hypertensive treatment, again there is definitely a role of magnesium sulfate, and if not controlled with magnesium sulfate, then use of other anti-epileptics. But mind well, this is secondary to hypertensive disorders of the pregnancy, so definitely magnesium sulfate, either the pre-chart regime or the Zuspan regime, depending upon the situation or the availability of the pumps and the monitoring facilities. For infusion pump, definitely we can use either a Zuspan or the pre-chart regime. Mechanical ventilation, usually, yes, when it was required, it was performed. ICU admission, almost in 60% cases, it was not necessary. I'm not saying that it is not necessary, but in this case, report it was shown that it was not necessary where required. We should admit the patient. Full remission was seen in almost 94% of the cases, and long-term complications in 4%, but death was almost, when the literature review was done, in very rare, almost 2% cases. Acute respiratory failure, which is another complication we all know. Acute pulmonary edema, it may complicate the severe preeclampsia and is frequent reason for critical care unit admission associated with high maternal and perinatal mortality and morbidity. Usually there are two types, the non-cardiogenic and cardiogenic. When there is severe hypertension and when there is increased afterload, we can say definitely it is going to cause LVF and thereby the respiratory failure. While where it is non-cardiogenic, it is the ARDS, it is the acute respiratory distress syndrome or respiratory distress syndrome. How does preeclampsia leads to ARDS? We know there is widespread endothelial dysfunction, which will increase the capillary permeability. Because of hypertension, definitely there will be an increased hydrostatic pressure. There will be reduced plasma oncotic pressure in the postpartum period, and all this will lead to ARDS. Yes, we can see this slide very well. The good pictures, chest X-ray radiograms, they are being shown. If we see the pulmonary edema picture, we all know that the that mouth and all, sudden respiratory failure. But when we see the radiogram, bilateral air bronchogram, it shows central patterning pattern. Here, along with right side pleural effusion, we can see in this radiogram, the first one. Second, it is a typical picture of ARDS. There is diffuse bilateral coalescent opacities. While when we see the radiogram of the pleural effusion, which is on the extreme right, there is a left hemithorax, right, upper dome has gone up, obliteration of the right costophrenic angle, and it is showing all of the mediastinum that has been shifted to the right. So these are certain of the features we want to just show here, that how we can make out from the radiograms. Some of our obstetrician friends, they may say that we may not be able to find such patients. Ideally should be managed in the tertiary care unit and with the help of the physician or the chest physician or the critical care specialist, we must treat such patients. So admission to the critical care unit, multidisciplinary involvement, ventilatory support if needed. But our role comes when the antihypertensives, antibiotics, they are to be needed. And once the patient is stabilized, we must go for the delivery of the patient. Second, very important is HELLP syndrome. HELLP is H, E.L. and L.P. H is from hemolysis, E.L. is from elevated liver enzymes, and L.P. is from the low platelets. Hemolysis, definitely it will be obvious from the abnormal peripheral smear. When total bilirubin is more than 1.2, it is because of the hemolysis. And reduced serum hepatoglobin, these are the classic features of hemolysis. Elevated liver enzymes, when we say the serum aspartate aminotransferase GOT more than 70 unit per liter. The normal values of 20 to 20 unit per liter during pregnancy, normal pregnancy, it may rise up to 20 to 40. But when they rise twice or thrice the normal level, that means where they are more than 70 unit per liter, then it is significant and we say that there are elevated liver enzymes. Even LDH, the normal value of up to 200, fine. During pregnancy, it may rise up to almost 400. But when the values go beyond 600 to 800, definitely it is the elevated thing. And when we see the low platelets, again, during routine preeclampsia or hypertensive disorder, there will be certain reduction in the thrombocytes or in the platelets. But when they go below 1 lakh per cubic mm, definitely it is a low platelet or the thrombocytopenia, and we should think of the HELLP syndrome. Bahaim Sibai, the person who has done a lot of and maximum work on the hypertensive disorders, he has noted that hypertension may be absent almost in 20% of the cases, or maybe mild, and maybe severe only in 50% in women diagnosed with HELLP syndrome. Therefore, the diagnosis of HELLP syndrome cannot necessarily be ruled out in the normotensive patients. So when the normotensive patient comes, and if she has hemolysis, if she has elevated liver enzymes, if she has low platelets, one should be very, very cautious that yes, she might have HELLP without having the hypertension. So we have to be very careful. Patient can rapidly deteriorate after the initial symptoms. So early diagnosis gives the best chance. Dr. Sanjay Gupte and Dr. Suchitra Pandit, in their many lectures, they have always stressed upon the point that excessive vomiting during pregnancy, in second trimester especially, or in the second half of the pregnancy, there has to be a high index of suspicion that whether my patient is suffering from the HELLP syndrome, and we should do her investigations. This is a very important point. The initial evaluation in women diagnosed with HELLP syndrome should be the same as that for the severe preeclampsia. We know the patient should be cared ideally for at a tertiary care center. Management initially should include maternal and fetal assessment. We know control of hypertension, initiation of magnesium sulfate infusion, because this is a case of severe hypertensive disorder, severe HDP, severe preeclampsia. So we must give the dose of magnesium sulfate. Then correction of the coagulopathy present, and the initial maternal stabilization has to be done. Hastily one should not go for the delivery as was thought earlier. That patient of severe preeclampsia, the patient of HELLP syndrome, we will deliver them. Deliver karte. No, it should not be like that. We have to do the maternal stabilization first. Immediate delivery should be performed in patients more than 34 weeks again after maternal stabilization. In patients less than 34 weeks without proven lung maturity, corticosteroids should be given and delivery planned in 48 hours, provided there is no worsening of maternal or fetal status in the meantime. The use of steroids, of course, one should not go in the debate of which should be used, the beta or dexa. It is very clear that in India, the betamethasone salt, which is available or recommended in the Western world, that is not available. So dexamethasone is recommended and should be used. The volume expanders, plasmapheresis, antithrombotic agents in patients with HELLP, they have produced only marginal results. They have not given the promising effects. Some evidence definitely suggests the benefit of steroid therapy for improvement in maternal condition, but mind well, not in all patients, so it is not the treatment. The steroids is not the treatment for HELLP syndrome. In certain cases, it has shown some good effects. Beware of this. Why? Because conservative management of HELLP syndrome poses a significant risk of abruptio placentae, pulmonary edema, adult respiratory distress syndrome, ruptured liver hematoma, acute renal failure, DIC, eclampsia, intracerebral hemorrhage, and maternal death. Therefore, a very cautious word that expected management past 48 hours is not warranted for potential minimal fetal benefits when weighed against the profound maternal risk. That we have to keep in mind. The next complication I am going to deal today is hypertensive crisis. Because many a times we may think here, my maximum patients I am used to treat, they are from 140/90 to 160/110, but what if there is a hypertensive crisis? Which agent should I use? Although not specifically addressed in the JNC7, even the rate report has come, the patients with a systolic blood pressure, 179 millimeters of mercury, or a diastolic blood pressure, 109 millimeters of mercury, more than this, they are usually considered to be having hypertensive crisis. So anything more than this, they are in hypertensive crisis. We all know that any blood pressure more than 140/90 millimeters of mercury, we are taking it as hypertensive disorder. The recent even certain guidelines of ISHHP, they say that even 135 or 85, more than 135 or 85, we should consider as HDP. When it is more than 160 systolic and more than 110 diastolic, we call it as severe preeclampsia or severe hypertensive disorder. And when it is more than 179 systolic and 109 diastolic, we are calling it as hypertensive crisis. I have purposefully given all the ranges. What is hypertensive urgency and emergency? Hypertensive urgency occurs when the blood pressure spikes without target organ damage. This patient should have their BP reduced within 24 to 48 hours. That means there is certain time we have that where we can minimize the blood pressure, stabilize the mother and go ahead. While in hypertensive emergency, that means severe blood pressure with end organ damage. And blood pressure must be reduced promptly, but again, within certain frame. What is that? I'm going to show that. Why we are worried about this complication? Why I have chosen this complication? Because again, this is a vicious cycle that with severe hypertension, there is more endothelial injury, there is more fibrillary necrosis, ischemia, again leading to the spikes of the vasoactive amines, which is again leading to the hypertension. This is a vicious cycle. And in certain cases, time comes that we say that God knows what is going to happen. But if we intervene in between at a proper stage and with proper medicines, a proper hospital with proper help, definitely we can reduce the morbidity and mortality out of this complication. The organ damage associated with hypertensive emergency may include changes in mental status such as confusion, stroke, cardiac failure, unstable angina, pulmonary edema, myocardial infarction, aneurysm, aortic dissection, eclampsia. Usually when we think of the complication of the hypertension, the eclampsia comes in our mind, PRES comes in our mind, HELP comes in our mind, but we should be very aware that the cardiac complications, they are also on the rise. So cardiac failure, unstable angina, MI, pulmonary edema, they are the worst with this hypertensive crisis. Symptoms, they may vary from patient to patient. Headache, altered level of consciousness, focal neurological signs, when there will be hypertensive encephalopathy. In other patients, when there are cardiovascular manifestations, yes, there may predominate like angina. In some patients, when there is severe injury to the kidneys, it may lead to acute renal failure. There will be oliguria, hematuria, renal shutdown. In pregnant patients, mainly, yes, visual field defects, severe headaches, seizures, temporary blindness, then acute cerebrovascular accidents, severe right upper quadrant abdominal pain due to the tense liver capsule, congestive cardiac failure, oliguria, eclampsia, what complications they are there in pregnant women. Ideally, the patients with these such crises should be hospitalized. Intravenous lines, I have not written lines, ideally with, they say 14 or 16. If it is not available, at least with the 18, please use the large bore cannulas in all hypertensive disorder patients. Because in latter part, when there is a sudden collapse, there is nothing in our hand if we have not put the large bore cannulas. Please forget about the scalp veins. Please forget about the blue small bore, that 22. Ideally, it has to be 18 green or the gray 16. That has to be there ideally. If not, at least 20. But please don't go below that. Laboratory studies should include the complete blood count, differential rate count, platelet count, blood chemistries, and when required, the coagulation assessment. Urine analysis, yes, or protein glucose blood class, blood and cast, assessment for end organ damage. In such cases, please do not forget the fundoscopy, the ECGs. Antepartum patients, yes, the fetus is still inside the womb. So please do not forget the electronic fetal heart rate monitoring, the ultrasonography or the Doppler whenever required. Lowering the blood pressure. There has to be a policy, and this is very important. That's why I have given a specific MCQ during this webinar. You might have received that. Ideally, the drug of choice in hypertensive crisis is sodium nitroprusside, and we should all pray to the God that no one should come across that no one such patients, and time should not come on anybody to use this drug. Other drugs such as nitroglycerin, nifedipine, labetalol, esmolol, they can be used. Till then, we were talking only about nifedipine and labetalol. But if we find the world literature, if we find the literature of the ICUs, the critical care specialists, those who are using certain drugs, yes, nitroglycerin, labetalol, esmolol, nicardipine, these are the drugs which can be used even during such crisis during pregnancy. There are risks associated with too rapid or excessive lowering of the blood pressure. So the aim of the therapy is to reduce the mean arterial pressure by no more than 15 to 25%. And that's why I said that the blood pressure should be reduced promptly but slowly. Small reduction in blood pressure in the first 60 minutes of therapy, working toward a systolic level of 155 to 160 and a diastolic level of 100 to 110 is recommended. It should not suddenly come down to 140 or 90, 140 by 90, because please mind well, fetus is still inside the womb. There can be sudden antepartum hemorrhage. There can be sudden myocardial infarction to the mother. These two complications are the worst. Or even the cerebral hemorrhages are very common if we suddenly take the blood pressure down. I'm not going into the drug details, but definitely this slide is very important because all the drugs which can be used I have given, and the drugs at a glance. Labetalol we know how to give, that is 20 milligram IV, then 40 to 80 milligram every 10 minutes up to maximum dose of almost 300, or continuous infusion at the rate of 1 to 2 milligram per minute. We all know the Parkland Hospital regimen of 10, 20, 20, 40, 40, 80. Total it should not go across 300 with the interval of 15 to 30 minutes. It has to be given as a slow injection. Nifedipine, again, yes, this is again a beautiful drug because we can use orally. 10 milligram per orally repeated in every 20 minutes, 30 minutes. Even there are now 20 milligram slow release tablets. Never use sublingual depine. I always in my all talks given a line that using sublingual nifedipine is a crime. One should remember that. It has to be given per orally. We can repeat definitely, and within 24 hours a dose of almost 240 milligram can be given. So we can use these drugs safely. While using all these drugs, we have to monitor the blood pressure. We have to monitor the oxygen saturation. We have to monitor with ECG monitor. We have to monitor the pulse rate of a patient, and then we have to titrate the dose of these antihypertensives. Hydralazine definitely, but it requires a lot of titration, though many papers or many institutes are saying that, yeah, hydralazine is best and all, but it requires a lot of titration. Nicardipine, yes, as a continuous infusion at 3 milligram per hour. All my ICU friends will agree that yes, esmolol and nicardipine, they are the best one. In such situations, even the nitroglycerin. I'm sorry, nitroglycerin was not added, I'm sorry here, but yes, nitroglycerin is an again promising agent in the hypertensive crisis, I'm saying. Sodium nitroprusside, some of the friends, they might have used, they might have seen this drug. It has to be protected from the sunlight, and I will say, unfortunate to use these drugs when I was working in one of the hospitals in Mumbai in critical care unit. But the patient was saved, but time should not come to use this drug. 0.5 to 5 or 0.25 to 5 microgram per kg per minute IV infusion. Risk of fetal cyanide poisoning with prolonged treatment is there. We have to be very careful. Eclampsia. A lot is being talked about eclampsia. We know the occurrence of a convulsion in association with syndrome of preeclampsia is a serious complication of pregnancy. But again, Dr. Girijawag, Dr. Alpesh Gandhi, and Dr. Guptesar has always said in their talks that there is no necessity of preeclampsia to cause eclampsia. So that means the world is seeing a lot of patients of atypical preeclampsia or atypical eclampsia. That means there won't be hypertension. There may not be proteinuria, but the patient may have the convulsion, and still that is eclampsia. And I think this is the thing where I should say that now we should think of the nomenclature of all these symptomatology or all these symptoms and signs together. And now we should not say that this is a preeclamptic disorder or eclamptic disorder, and together we should say that this is a gestosis. This is the reason. If you remember the first slide, why I was talking about the gestosis, the reason is that. Okay, so eclampsia is the occurrence of a convulsion. Call for help, that has to be there. First and foremost, call for help, secure the airway, avoid the tongue bite and other injuries, oxygen supplementation. We have to do the Foley's catheterization, of course, after the initial stabilization. Don't put the Foley's catheter initially because we are going to stimulate that patient. So ideally, once the patient is stabilized, then because for the initial dose of magnesium sulfate, no need of the urine monitoring. That means when we give the first dose or what we call it as the initial dose of the magnesium sulfate, the loading dose of magnesium sulfate, we must not be knowing what is the urine output and all. There is no necessity. The urine output monitoring is required for the further dosages of the magnesium sulfate. That we have to keep in mind. As I said again, the large bore IV cannulas preferably at 2 places. Through that only the lab should be collected. Without waiting for the results, magnesium sulfate regimen must be started. Somebody will say that, oh, there are so many differential diagnoses in India. Mind well, during pregnancy, there is little raise in the blood pressure, or any pregnant patient for that matter with convulsions, the first and foremost diagnosis in 99.99% cases is eclampsia, and we have to give Sanjeevani. I always say Sanjeevani in eclampsia is magnesium sulfate. Which regime to choose? Again, there are two regimes. We know Dushpan regime or Pritchard regime. Forget about the low dose regimens. I am not discouraging. I am not saying no to the regimens, but we have to universalize. And as WHO says, as Indian government says, as NHM guidelines says, as FOXI guidelines says, ICOG, Justosis guidelines says, ISHHSP guidelines says, that either Dushpan regime or Pritchard regime for India. Again, I will say Pritchard regime, because many of us have, we don't have the infusion pumps or the monitoring facilities. So Pritchard regime will be the best. Loading 4 gram IV, not stat, but in 12 cc distilled water over 20 minutes. And then 5 gram deep intramuscular in each buttock 4 hourly, and deep, seeing 4 hourly, seeing the initial dose, loading dose is 14 gram. 4 gram IV as a 20% solution, diluted solution over 20 minutes. Then 5 gram in each buttock, so total becomes 14. In each buttock it will be a deep intramuscular. We have to add 0.5 cc of the 2% xylocaine as government recommends to minimize the pain. Ideally, we have to use the green or the black needle, that means the large bore and long needle. Maintenance dose 5 gram deep intramuscular in alternate buttock 4 hourly. We have to monitor the urine output 100 ml in 4 hours, last 4 hours. The tendon reflexes is present, they are present. And lastly, the respiration rate is more than 16. That indicates that there is no much serum magnesium level that has caused the, it has crossed the level of toxicity. That these are the indicators. And if they all are present, definitely we can give the next dose. If one of them is not present, we have to wait. Once all of the 3 they present, that means tendon reflex plus urine output is there, and the respiration rate has been more than 16, yes, then only the maintenance dose has to be given. Unfortunately, if there is a case of magnesium toxicity, don't worry. We have to use calcium gluconate, follow the rule of 10 gram over 10 minutes, 10%, and again 10 ml over 10 minutes with ECG monitor. But mind well, calcium gluconate is more dangerous than the magnesium sulfate because it can stop the heart in systole. So the drug is, this drug is more, antidote is more dangerous than the drug. Very few have come across the magnesium toxicity only when they have given as a shoot or as a what we can say the stat injections. When they are given by the proper protocol, slow injections, absolutely there is no problem. Dushpan regimen, we know loading dose is 4 gram IV as shown, 12 cc distilled water as a 20% solution, and the maintenance dose is very easy, 5 gram in 500 ml RL at 1 gram per hour. If infusion pump is there, it's very easy to follow this regimen. So this is another complication, and as usual we have to use the antihypertensives. Once patient is stabilized, then definitely even the steroids are given. Here the rescue dose, single dose of steroid even is sufficient. Once everything is fine, fantastic. Definitely if there is a favorable cervix, definitely we can go ahead with the labor induction. And the cesarean section is for obstetric indications only. All eclamptic women we should not go for cesarean section. There is no necessity. We are ending towards our time limit. I will go through other complications. Quick, the other is acute kidney injury. It may occur in context of severe preeclampsia. In preeclampsia, due to the underlying endothelial dysfunction, the predominant abnormalities seen on renal histology are to the endometrium and glomeruli. Creatinine clearance by measuring 24-hour urine Creatinine remains the gold standard of GFR, even the gold standard of GFR estimation in pregnancy. Any sustained fall in output less than 0.5 ml per kg per hour or rising serum creatinine should alert the clinician of likelihood of acute kidney injury. Serious complications, we know cardiac failure, cardiomyopathy, acute EMI that we have to keep in mind. Uteroplacental complications, placental abruption, FGR, oligohydramnias, preterm delivery. As I said, on all these topics, probably we are going to arrange a separate webinar. The DIC, we know bleeding as in the incision is being closed and incision side bleeding. In preeclampsia, there is a vasoconstriction which affects the blood flow to the liver. Liver releases coagulation factors, we know. So the DIC and all these hematological complications, they will be dealt in a separate webinar. Coming back to the management principles again of all these complications, very neatly designed antihypertensive therapy, avoidance of the antihypertensive agents like atenolol, ACE inhibitors, ARBs and diuretics, magnesium sulfate to prevent and treat the eclampsia, oxygen administration, pulse oximetry, fluid restriction, planning the mode of delivery, active management of third stage of labor management, use of corticosteroids, conservative management of delivery, continuation of antihypertensive following the delivery, one should not forget, formal postnatal follow-up and review, preconception counseling for next time. Fluid management, I wanted to focus on this, that fluid restriction is advisable to reduce the risk of fluid overload in the intrapartum and postpartum periods. In usual circumstances, total fluids should be limited to 80 ml per hour or 1 milligram per kg per hour. Over the last 20 years, pulmonary edema has been a significant cause of maternal death, and this has often been associated with inappropriate fluid management. No 5% dextrose. If at all IV fluid has to be used, it has to be ringer lactate or normal saline, that too 80 ml per hour. The regime of fluid restriction should be maintained until there is a postpartum diuresis, as oliguria is common with severe preeclampsia. If there is associated maternal hemorrhage, again the fluid balance is more difficult and fluid restriction is inappropriate, so it is a double-edged sword, giving IV fluids in the hypertensive disorder. So we have to be very particular in the input as well as the output and the hemorrhagic loss as well. So to summarize, patients with severe HDP, HELLP syndrome and hypertensive crisis are at risk of maternal and perinatal morbidity and mortality. Every effort should be made to optimize outcomes for both. Risk to the fetus relates largely to the gestational age at delivery. Risk to the mother can be significant and include development of DIC, intracranial hemorrhage, renal failure, retinal detachment, pulmonary edema, liver rupture, abruption. Therefore, astute and experienced clinicians should provide care for these women. Experience comes again by experiencing and working and saying no to such patients. So take home message, understand the disorder, predict with screening, Gestosis score, use Gestosis score. At the end, I think they are going to show my email ID, or I don't know. It is drmango, drmango @rediffmail.com. Purposefully, I am giving. This is not an election agenda or anything personal thing, but this is for the Gestosis score. If you have any query and if you want, definitely you can write me on that. drmango @rediffmail.com, or you can please visit the website of the FOXI or ICOG, where all these guidelines, the Gestosis score and etc., they have been given. Early diagnosis, prevent with ecosprin 75 milligram plus calcium 1 gram. Do not confuse about the dosages. Early diagnosis of complications, tertiary level care where possible, expected management without maternal and fetal compromise, and protocol-based management, that is fluid balance, prevention of seizures, antihypertensives, steroids for fetal lung maturity, and management of complications. We can minimize the complications of hypertensive disorders of the pregnancy. So at the end, I would like again to thank Dr. Alpesh Gandhi, our president of the FOXI, Dr. Sanjay Gupta, Secretary General of the World Gestosis Organization, Dr. Suchitra Pandit, who is President of the India Justice, Dr. Parag Beniwale from ICOG, and all the team of the Foxy ICOG and Justices. I would like again say that tell the world to stay at the home, to stay safe from COVID-19. I repeat, tell the world to stay at home, to stay safe from COVID-19. But I appeal, I urge to all that take the precautions and keep the medical services open. We have kept our services open. And please visit the Foxy website again because Dr. Alpesh Gandhi has taken efforts, and the COVID-19 and the pregnancy guidelines, they have come into the picture right now, and they are available on the Foxy website. So I thank you again, and I think I'm open for the discussions. I again thank to my Zydus and DocMode team, Mr. Hitesh, then Asma, Tejas, who have helped me a lot because I was little illiterate about this IT work. And I thank Gaurav, and his team for helping me. He's actually my nephew in arranging these IT things in the lockdown period. Thank you. I'm open for the so Dr. Shilpa, again I'm saying that definitely it is 75 milligram, because though recent guidelines have shown it is only one paper, and the rest of all the world has agreed that yes, it is a 75 milligram, and definitely there is no single study in the world which has done the comparison of 75 milligram and 150 milligram. In fact, I am urging through this webinar that those who can design certain studies, please go ahead and do the studies, but till now 75 milligram definitely helping. The second question is again related to the same from Raipur, Dr. Pavan BC. He has asked that does 75 milligram aspirin apply to all at-risk patient? Any particular indication for 150 milligram? I don't find in India there is any separate indication for 75 to 150, but if we apply the rule that 1.5 to 2 milligram per kg body weight, 1.5 and 2 milligram per kg body weight, then probably in very obese patients, definitely one can add about the more dosages, see that the to tolerability, but otherwise 75 milligram, because again all the articles have clear-cut shown that the actual dose which is required is 45 to 60 milligram. So that means we are giving more than what is sufficient. In again relation, third subject, the question is from Dr. Tushar Garde, Mumbai. Does aspirin has any side effects? And just a minute. Does aspirin has any side effects? Depending upon symptoms, do you recommend its a dosage? Actually, the low dose aspirin usually does not cause any side effect. Very few women who are very much sensitive to the aspirin, they may have the hyperacidity or like that, but usually not been seen. Dr. Rakesh Shah from Surat, he has asked, you have suggested thrombophilia in more than 3. Can you classify on what basis it is concluded? Okay, sir, very good question. Actually, the justosis score, if you remember the NICE guidelines or even the COG guidelines or Indian guidelines for that matter, all these clinical factors, they are classified as mild, moderate, and very high risk, right? So those factors who are very high risk, and almost they have shown that their presence is going to cause the hypertensive disorder in that women in more than 40 to 50% of the cases, they are called as high risk factors, and they are given the 0.3. And all such women should be given directly, they should be started with ecosprin 75. This is the basis. The next question is, just a minute, Dr. Ketaki H from Pune. Urine analysis can be measured as clinical manifestation. Can you explain how can we detect HDP on the basis of that? Okay, again, though it was said that initially proteinuria was in the definition of the preeclampsia or of the hypertensive disorder. But now in all 2019-20 or 2020-20 guidelines, if you see, we are not giving much significance to the presence of proteinuria for diagnosing the preeclampsia. Definitely when it is present and depending upon the degree, yes, it is a prognostic indicator. Definitely, or it can be the sign of worsening of the condition. That's how the urine analysis can be taken into consideration. From Nagpur, Dr. Saili P. She has asked question. Fetal heart rate can be a sign of detection. Normally, it's shown what the effective urgent measures to be taken. Actually, fetal heart rate definitely see the bradycardia or the fetal tachycardia, that is less than 120 and more than 180, definitely it shows that the fetus is compromising, right? So depending upon that, definitely if there is a already mother with HDP, and if such findings are coming on the either electronic fetal monitoring or the routine fetal monitoring, that means the baby is compromising. We have to do probably immediately the amniotic fluid index and the Doppler findings if available, and depending upon that, the maturity, we have to take the decision.
Yeah, so Dr. Parag Biniwale from Pune says, well presented, Gorakh. Then his question is, Gestosis score is definitely the simplest scoring system. We all need to validate it by a specific scientific manner.
Right. Yes, sir. Thank you very much. Actually, definitely, already it has been scientifically proven that all the clinical factors, they are to be taken into consideration while predicting the preeclampsia, and all the international and national guidelines, they have accepted that it is the clinical factors. Some are saying mild, moderate risk factors, some are saying 2 moderate, 1 mild, etc. What we have done in India, it is the proper quantification. And again, through this platform, I request all of you that that score is available on the website of the ICOG. Please download from there, and please try to apply it on your patients. Then definitely you will realize, initially when you read, you will say, every patient may fall into the category, but it is not so. Once you start using that, you will realize, this patient, I was not thinking she will end up in this at-risk category, but you will get slowly. Another thing that this is a very simple methodology, right? 50 पैसा 50 पैसे का एक कागज जरूरी है जिसपे हमने ये जेरोक्स पे लिया है. Even our sister, during taking the history, the nurses, our junior doctors, they can do. And if we do at every visit, then this is dynamic, because there is a mean arterial pressure. If it is more than 85 millimeters of mercury, we have given the point as 1. So when we have applied till date on almost more than 200 patients, and we have seen that in the last part of the first trimester or in the first part of the second trimester, I have seen that in certain patients, especially, again, it is an observation that those who are endocrinologically abnormal, that means either hypothyroid, GDM, or obese patients, we have seen that MAP start increasing. And in such situations, initially, when we observed, our patient was Gestosis score 2. But so twice she was seen, her Gestosis score was 2. But at a certain visit, we found that her MAP was 96. so which was more than 85, and now she becomes J-stosis score 3, and there we start the aspirin. So the beauty of this J-stosis score is that we can apply, we can ask the question again and again to the patient, right? So, or even we can say that all those questions we have asked on day 1, day 2 visit, but MAP, yes, it will be seen on every visit, and we can add accordingly. Thank you very much. Hitesh, the next question, can I?
Yes, sir. Yes, sir. So the next question is from Ghansham Murlidhar Magar from Aurangabad.
Okay.
So it is placental malformation like cyst in placenta a high risk factor for HPT?
Okay, right, definitely. Though it is not clear-cut said, but definitely when there are presence of placental cyst, it has been correlated that such cases, they are going in the latter part of pregnancy into the hypertensive disorder. Definitely, yes.
Yes, sir. Next question is from Surya Deva Sailaja from Krishna.
Okay.
So will you please repeat fluid management?
Will you?
Please repeat fluid management.
Okay, okay. Right?
Yeah, Surya Deva Sailaja.
Okay. Dr. Shailaja, definitely I have gone through the details, not much details, but yes, see. What I am saying again and again here and even in other talks that fluid restriction is advisable because again, as I said, giving more fluids is a problem, giving less fluids is a problem. So we have to be balanced while doing this fluid management. Therefore, we have to chart out that I am going to give this much fluid to this patient in this much time. So ideal given is 80 ml per hour. So if we see within 24 hours, almost it will be, I think, 24 into 80. That means almost 2 liter. Again, choosing the IV fluid. So here again, when we are using the crystalloids, again 5% dextrose or DNS should not be used. It is the ringer lactate or the normal saline should be used. The question will be why? Because the 5% dextrose, if we know, it is going to go out into the third compartment. So that is another problem. So if you see, when we use this 5% dextrose, in such patients, we find a lot of edema and all these patients are with swollen face and all. So ideally RL or NS and that to 80 ml per hour. And we have to chart out the input as well as the output chart. And if you see the last line, that if there is associated maternal hemorrhage, last line, that fluid balance is more difficult because again that much amount we have to shift. So here again the plasma, FFP, whatever what we give, again all those things in certain emergencies we have to chart it up. Otherwise, during the management of hemorrhages in such patients, again we may land up in another trouble of pulmonary edema. So we have to be very careful in IO charting. Next question, please.
Yes, sir. The next question is from Mohini from Bhubaneswar.
Okay.
Role of high dose calcium in prevention and mechanism.
Okay. Actually, it has been given that it is a very good evidence which was given in the WHO guideline, and they say that 1 to 1.5 gram of the calcium has to be given when we know that this lady is at risk for the preeclampsia, but they say that in the calcium poor settings. If we see our Indian women, apart from the affluent society, I think all of us, they are not eating that much amount of calcium, that much amount of milk, that much amount of custard apple or many things In certain parts of the country, definitely it is there, but in almost more than I can say 60 to 70% of the women, the daily requirement of the calcium definitely already it is increased in the pregnancy, and we are supplying them with only 500 milligram of the calcium. But if we supply them with 1 to 1.5 gram, definitely it is going to prevent the hypertensive disorder. In our settings, when we have seen that even in many cases of IVF, I can, though it is not right to say, but these are the anecdotal cases, studies going on. But yes, last 26 IVF cases, we have seen that all the justices more than score almost more than 6. They are conducting very well with 75 milligram of the aspirin, 1.5 gram of the calcium, and remaining things.
So next question is Parul Singhal from Noida.
Okay.
Why lose dose regime of MGSO out of place?
Why low dose? Okay. Out of place. It is not like that. See, actually, what has happened, whenever we are using or recommending any regimen, then we must have the proper trials. If we see the DACA regimen or if we see the other regimens, they are the other low dose regimens for that matter. There are no much data which was seen, and therefore, yes, the Pritchard and Zuspan regimen they are recommended. But here again, I would like to mention a regimen from Solapur, Dr. Suman Sardesai, and she has a very good data on low dose regimen. But again, I would request that, yes, I request Madam through this webinar and all of you that please conduct more and more studies at more places, and probably then we may come out. Same is about Dr. Joshi from Bellary, who is conducting many researches there. So we all should come together and probably give data to each other, and we should try these low dose regimens, but in the form of proper research settings, and then I can say. But till then, I will recommend Pritchard. If the best facilities are available for monitoring the IV regimen, then this part.
Yes, the last question is Dr. Saurabh Birthare. So, Gravida 3, patient 32 years old. Her first ANC visit at 6 weeks. Her BP is 160 by 106 mmHg. She is not a case of essential hypertension previously. No HOPIH in previous pregnancies.
Okay.
Whether to start ecosprin along with labetalol or nifedipine.
Okay. Again, this is a very good question. If you are finding only single reading, then probably we advise that please institutionalize the patient for at least a day, 24 hours, monitor her blood pressure. When she has this much amount of blood pressure, kindly do the routine investigations, whether she is not in any complication, because all those we have to see even on the first visit. And if again we are finding that yes, she has second reading as well, and she is now classic case of hypertensive disorder, then yes, we have to start antihypertensive. Which antihypertensive to choose? Before that, if only single reading was there and remaining all readings were normal, remaining all the investigations are normal, then what you should do? Ideally, then we can allow that patient to go home, but we have to inform her as well as all her relatives that beware, though there was only one reading which was high, you are at very high risk. So please either monitor at your place or please do visit again and again and keep watch on such patient. The second part, that if she is hypertensive now, then what hypertensive to choose, whether labetalol or nifedipine. Again, though it is said in many books that labetalol is number one, in many books, nifedipine number 1. We here at Justosis and at Foxy, we say that it's a very good thing you can monitor is the pulse of a patient. I always recommend that please use pulse oximeter to monitor every single pregnant lady. You will find many things and you can prevent many complications. If we know that the pulse of a patient is more than 100, then I will recommend that labetalol will be the best choice for orally. And if the pulse is less than 100, then nifedipine is the choice for the as an antihypertensive, because those patients who are already tachycardic, if we use nifedipine, these patients, they may come up with severe headache, and then there will be a confusion that whether this headache is as a side effect of the nifedipine or it is a premonitory symptom of the HDP. So a small dictum you can take, or this is a good take-home message, that if the pulse is more than 100, then the better drug of choice will be labetalol unless until it is contraindicated. And if the pulse is less than 100, the better choice again will be nifedipine, but here again, tablet nifedipine, usually the SR formulation, that is slow release formulations, never sublingual capsule. Okay, so I thank again, I thank Hitesh, I thank Asma, Tejas, Paulson, all those, the Docomo team. Then I thank Zydus, and again, I thank you all that during lockdown period from all parts of the country you have gathered. I thank Dr. Alpesh Gandhi, President Foxy, for this great idea of the webinars. And I think definitely it is fruitful. And again, as I said, I appeal to all of you that on 5th of the March, as our Prime Minister Narendra Modi ji has said, that please gather at your doors or balconies, and please एक दिया जलाना है हमें, as he has rightly said, and tamasoma jyotirgamaya, that will definitely fade all these things. So thank you very much.